Good afternoon, and thank you for the opportunity to share our work. Fenestrated EVAR has rapidly become the preferred method for endovascular management of juxtarenal aortic aneurysms. Unfortunately, fenestrated EVAR suffers from up to a 25% risk of reinterventions. Of these complications, the most devastating is arguably thrombotic events, with occlusion of renal stents resulting in significant morbidity. In our center's experience, we've noticed that a large number of patients treated with larger device diameters suffer from these complications. This led us to the question of whether or not there's an underlying hemodynamic issue related to large endografts, which may predispose patients to thrombotic complications. This study sought to utilize patient-specific computational fluid simulation methods to investigate these hemodynamic parameters and potentially elucidate a predictive mechanism that can identify patients at risk of thrombotic complications. This is a retrospective study. We analyzed patients from our own institution's prospectively managed database of patients treated with fenestrated EVAR. We divided patients into two groups: patients treated with large devices with diameters between 34 and 36 millimeters and small diameters between 24 and 26 millimeters. For this study, we excluded intermediate diameter devices. We then used Vascular, which is an open source computational fluid dynamic modeling platform developed in-house in the lab of Dr. Allison Marsden here in the School of Engineering. And from this, we can use pre and post-operative patient CT angiograms and develop 3D models. You can see here in panel A and B. The preoperative model is shown in panel A, post-operative model is shown in panel B, and C, D, and E represent the renal flare geometry accurately. We then use patient-specific inflow and outflow boundary conditions, which are then scaled to patients' body surface area, heart rate, blood pressure, in order to create a patient-specific flow model, which has been validated in prior studies. And these computations are then performed on a 72-core high-performance cluster. From these simulations, we can then do a couple of things. We can visualize hemodynamic parameters and also extract quantitative hemodynamic parameters, including arterial pressure, flow rates, and for the purposes of this study, time average wall shear stress, which is a measure of the amount of force a red blood cell would experience near an aortic wall or a branch artery wall, and particle resonance time, which is a measure of flow stagnation or how long a red blood cell spends in an individual volume of fluid. So looking at our total cohort, you can see that in this study, 36 patients are treated in total, 14 in the small endograft cohort, 22 in the large endograft cohort. There was a significant difference in terms of which patients suffered thrombotic complications, with large endograft cohort having up to a 45% risk of composite thrombotic complications, defined as either presence of renal stent occlusion or development of significant aortic graft luminal thrombus. There was a trend towards higher reintervention in the large endograft cohort, but this was not statistically significant and no difference in all-cause mortality. Looking at our focused hemodynamic parameters, wall shear stress and resonance time in the charts to the right here, you can see that there's a significant difference in wall shear stress and resonance time between both the large and small endograft cohorts, with the large endograft cohorts having a significantly lower aortic wall shear stress and the large endograft cohorts having a significantly higher mean particle resonance time compared to the small endograft cohort. Next, we wanted to evaluate within the large endograft cohort, which has a much higher risk of thrombotic complications, whether or not there's some hemodynamic signal that we can use to identify which patients suffers from thrombotic events versus those that don't. And these two graphs here, you can see that we plot delta wall shear stress and delta resonance time. This corresponds to the postoperative minus the preoperative values to depict the change in hemodynamics postoperatively. And you can see that patients with thrombotic events exhibit a significantly larger decline in aortic wall shear stress and a larger increase in resonance time postoperatively compared to those without thrombotic complications. On receiver operator characteristic curve analysis, we used values from wall shear stress and residence time to quantify threshold values in terms of the reduction in each of those parameters. And we found that a reduction of greater than 0.39 dynes per centimeter squared in wall shear stress resulted in 70% sensitivity, 83% specificity, and over a 7x higher odds of thrombus formation. And patients that have an increased residence time of greater than 0.05 seconds have similar sensitivity specificity metrics and over 8x odds of a thrombotic event. We can also use computational fluid methods to co-localize areas of wall shear stress with areas of maximal thrombus deposition. And in this figure, you can see here is the immediate postoperative CT scan. And on the right, the latest follow-up CT scan demonstrating newly formed thrombus within the graft. And below, you can see a heat map of aortic wall shear stress with the arrow pointing to the same area where there are low areas of wall shear stress shown in blue to the corresponding CT area of thrombus. In aggregate, 72% of cases of thrombotic events were able to be localized based on this method. In conclusion, patient-specific CFD simulation of fenestrated EVAR for juxtarenal aneurysms demonstrated significant endograft diameter dependent changes in local aortic hemodynamics. Patients treated with large aortic endografts tend to have a lower wall shear stress in the aorta, as well as a decrease in wall shear stress postoperatively. In contrast, residence time appears to be increased in those patients treated with large endograft diameters, and the residence time also appears to increase postoperatively for patients who then suffer from thrombotic events. Patient-specific simulation of hemodynamics provides a new method for thrombotic risk stratification after fenestrated EVAR. In the future, we hope to prospectively validate this tool to predict thrombotic risk. This would involve future studies with phase contrast MRI data. We also plan to expand this analysis to include intermediate diameter devices between 28 and 32 millimeters to better understand the overall effect of endograft diameter on these hemodynamic changes, and also apply similar methods to more complex repair, such as 4-vessel fenestrated repair and branched EVAR to see if we can predict similar thrombotic events in those cohorts. Thank you for listening.